Welcome to this video conference coverage from the 2024 American Society of Clinical Oncology annual meeting in Chicago, Illinois, and the European Hematology Association Hybrid Congress in Madrid, Spain. In this series of 5 episodes, our expert hematologists, oncologists, Dr. Sairah Ahmed and Anne Lacasse will review the most recent data for the treatment of patients with non-Hodgkin's lymphoma, including diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, chronic lymphocytic leukemia, and an overview of the hot topics in the field. Stay tuned until the end of the program, where Dr. John Winters from New England Cancer Specialists joins us for a discussion about how these data may impact community hematology oncology practice.
Hello, I'm Dr. Anne Lacasse from the Dana-Farber Cancer Institute. Today I'll be discussing the data presented at ASCO and EHA for the treatment of mantle cell lymphoma. Many of the resources we discussed during this program can be found on the Lymphoma Clinical Resource Center on www.exchangecme.com. 2024 has been an exciting year with the new CAR T-cell approval for the treatment of relapsed and refractory mantle cell lymphoma. Liso-cel was approved on May 30th of this year. The FDA granted accelerated approval to lisocabtagene maraleucel for the treatment of adult patients with relapsed and refractory mantle cell lymphoma who have received at least 2 prior lines of therapy, including a BTK inhibitor, an alkylating agent, and an anti-CD20 antibody. This was approved based on the MCL cohort from the phase 1 Transcend NHL 001 study. So in this study, 104 patients were leukapheresed. Liso-cel was infused into 88. This was a heavily pretreated group of patients. 30% of patients had received 5 or more lines of therapy. The median number was 3. 73% of the patients were 65 years of age and older. Almost 70% were refractory, and about half of the patients had BTK inhibitor refractory disease. Nearly 25% were TP53 mutated, and 8% had involvement of the central nervous system. The median time of follow-up was 16.1 months. And in the efficacy set, this included 83 patients from dose level 1 and dose level 2. The overall response rate was 83%, with a complete remission rate of 72%. The median duration of remission was 15.7 months and progression-free survival 15.3 months. The most common grade 3 or higher treatment emergent adverse events were neutropenia in about half of patients, anemia approaching 40%, and thrombocytopenia in 25%. Importantly, cytokine release syndrome was reported in about 60% of the patients, but the rates of grade 3-4 CRS were very low at 1%, and there were no deaths related to CRS. Neurologic events occurred in 31% of patients, but again, the grade 3-4 rates were low at 9%, and there were no deaths. Grade 3 or higher infections occurred in 15%, and prolonged cytopenias in 40%. So I think we'll need to look a little bit longer term follow-up of this study to sort of compare it back to Brexacel, but it is very exciting to have this agent approved. So now let's turn and look at frontline therapy for patients with mantle cell lymphoma presented at the 2 meetings. So the ECHO study, this study compared bendamustine plus rituximab with or without acalabrutinib in previously untreated mantle cell lymphoma. And this study showed us clinically meaningful improvement in progression-free survival versus bendamustine plus rituximab. There was a reduced risk of progression or death by 27%, with a 36% risk of reduction when censoring for COVID-19 deaths. The safety profile was consistent to what we would expect with the individual drugs. And this is really the first evidence of a positive trend in overall survival when adding a BTK inhibitor to frontline standard chemoimmunotherapy for the treatment of older patients with mantle cell lymphoma. This overall survival benefit is not yet statistically significant, but I think this study is very important given that in the SHINE study, where we looked at ibrutinib plus bendamustine and rituximab, there was an increased death rate in patients in the ibrutinib arm, leading to the voluntary withdrawal of ibrutinib in the US market. So the CHESS study was another study incorporating a BTK inhibitor. In this study, rituximab was added to zanubrutinib, followed by a short course of chemotherapy with high-dose Ara-C, dexamethasone, and oxaliplatin with rituximab for 4 cycles. Again, this was in previously untreated patients with mantle cell lymphoma. And the results were really quite impressive, with 92% and 94% of patients achieving a complete remission after 2 and 4 cycles of zanubrutinib plus rituximab, respectively. So the hope is that by starting with zanubrutinib plus rituximab, we may really be able to debulk patients and reduce the toxicity associated with this cytarabine-containing chemotherapy, while maintaining really the excellent outcomes we've seen using this sort of approach. And interestingly, the bone marrow MRD negativity rate in this study was very high at 92%. So the bovine study, which was designed out of Memorial Sloan Kettering, combines zanubrutinib, obinutuzumab, and venetoclax together, all 3 active agents in mantle cell lymphoma, in frontline treatment. And in this presentation, in the patients with older patients with mantle cell lymphoma, defined as 65 years and older, the preliminary data, this is early data, showed a very high overall response rate of 98% in 43 patients, with nearly 80% of patients achieving a complete remission. And the rates of undetectable minimal residual disease at 10 to the minus 5 by cycle 13 was really impressive. The follow-up is limited, and there are a substantial number of patients are continuing on therapy as this study is ongoing, and most of the patients have not yet completed the minimum of 2 years of treatment. So there's been a lot of debate over time about the value of maintenance rituximab when given after bendamustine plus rituximab chemotherapy upfront in mantle cell lymphoma. There was a small study from Germany, the MAINTAIN trial, which did not demonstrate an improvement compared to placebo, which was presented now 8 years ago at ASCO. This data has never been published. More recently, Peter Martin and colleagues put together a very large real-world data set of patients with mantle cell lymphoma and looked at survival outcomes using the Flatiron database. And this did show a significant improvement in both progression-free and overall survival when patients received maintenance rituximab after chemoimmunotherapy, including bendamustine. So presented at ASCO this year was a large multi-center study where rituximab maintenance was again looked at after the receipt of bendamustine plus rituximab in patients with mantle cell lymphoma. And this again demonstrated an improvement in event-free and overall survival. So I think now we can feel comfortable giving rituximab as maintenance in mantle cell lymphoma, and it really does seem to provide a significant benefit in outcome. So now we'll move on and talk about some of the abstracts that were presented in patients with relapsed and refractory mantle cell lymphoma. So we saw the long-term follow-up of the Nordic Lymphoma Group's MCL6 Philemon study. This study combined ibrutinib, lenalidomide, and rituximab as treatment in relapsed and refractory mantle cell lymphoma. And this was a highly active combination with an overall response rate of 86%. The median PFS was 17.4 months, and this compared favorably to the median progression-free survival of 12.5 months with ibrutinib alone from a pooled multi-center study in Europe with 370 patients. The combination also appears to be active in patients who have TP53 mutated mantle cell lymphoma, which is a significant unmet need. And the median progression-free survival in that group was greater than 1 year. And using this kind of strategy may be effective in getting patients to CAR T or allogeneic stem cell transplant, or hopefully in the future bispecific antibodies. The Simpatico study was updated in patients with mantle cell lymphoma treated with ibrutinib plus venetoclax, and this showed very promising efficacy with high complete response rates in both treatment-naive and the relapsed and refractory setting at 55 and 58%. With durable remissions in patients even with high-risk features such as TP53 mutations. So this was the largest single study cohort of patients reported to date. In the Transcend mantle cell lymphoma data that was presented looking at subgroup analysis, The benefit of liso-cel was seen across multiple populations. However, in patients who had been heavily pretreated, having received 5 or more prior lines of therapy, and disease refractory to prior BTK inhibitor, the responses were good, but not as durable as for other populations in the study. And for all patients, the durable complete remission rate was 72%. The median duration of remission, progression-free, and overall survival were 15.7, 15.3, and 18.2 months, respectively. The longer median duration of remission, progression-free, and overall survival were seen in those patients, again, who were less heavily pretreated and had not progressed on prior BTK inhibitor. And I think this is something that we see across the board. So we need longer-term follow-up of this study. Preliminarily, the toxicity associated with this agent seems to be less severe than with brexacaptogene, but we'll need to see with longer-term follow-up what the median progression-free survival and overall survival, how those compare up. So we also saw an updated analysis of the phase 1/2 study of fixed-duration glofitamab monotherapy in heavily pretreated patients with relapsed and refractory mantle cell lymphoma, including those who had been previously treated with BTK inhibitors. And this data is really quite impressive with response rates that are maintained beyond completion of therapy. So with a median progression-free survival follow-up of 17.2 months, the overall and complete remission rates are 85% and 78%, respectively. This data has led to the design of the GLOBRIGHT study, which compares single-agent glofitamab to standard of care. And on May 31st of this year, the glofitamab received breakthrough designation status by the FDA for patients with relapsed and refractory mantle cell lymphoma who have received 2 or more prior lines of systemic therapy. So now that we're all up to speed on the most recently presented abstracts for mantle cell lymphoma treatment from both ASCO and EHA, let's talk to Dr. John Winters, my community hematology colleague from New England Cancer Specialists, and hear what he's thinking about as he looks at these abstracts and thinks about applying the data to his patients.
Hi, Ann. Thanks for that great overview. I'm John Winters. I practice general hematology in the Portland, Maine area, and I do have a few questions. There are a lot of combination approaches when being studied in clinical trials for first-line therapy. When choosing a first-line agent, what factors do you take into account, and does it matter to you if you see CAR T-cell therapy in that patient's future?
Yeah, so it's a great question and something that I think we think about every day as we see new patients with mantle cell lymphoma. So I think one of the first things we're thinking about is what is the age and fitness of the patient? Is this someone that we're thinking may be eligible to receive cytarabine-containing therapy? If so, we may use a more aggressive approach. I think we are beginning to think about omitting stem cell transplant in patients, younger patients with mantle cell lymphoma, given the data from the Triangle study. And now that we're seeing these combinations of BTK inhibitors with bendamustine and rituximab, or even the study where patients started with zanubrutinib plus rituximab and then got chemotherapy, I think that's a very appealing option, because I think our patients, we see a lot of your patients coming down for a discussion of stem cell transplant, and it's really a big lift for the patients to think about coming to Boston and needing to be here, and it's really a lot of therapy. So age is something we look at. We also want to think about the biology of the disease. So when patients have blastoid variant or pleomorphic variant, or in particular have TP53 mutations, that particular group of patients we know do not benefit from autologous stem cell transplant, and they may not benefit as much from standard chemoimmunotherapy. So those are patients that we would reach for a BTK inhibitor containing regimen up front, hopefully get them on a trial. But I think comparing across trials, it's going to be really interesting to see, should we be combining everything or sequencing them? I think that's still an open question. If we do see an overall survival benefit when you combine acalabrutinib with BR versus BR alone, I think then we know we need to combine them. But you wonder if people get good mileage out of BR plus maintenance rituximab, and then you go to a BTK inhibitor, and then we're going to have things like bispecifics and CAR T available, looking at that overall trajectory, or should we be really trying to combine things where we may see more toxicity? When we think about, so if I see a patient who has blastoid or pleomorphic or TP53, I'm worried that that patient is going to have rapid progression, so I'm going to try to avoid bendamustine. I really do think bendamustine has a significant negative impact. I mean, there's good data out there in CAR T, but I also think it probably is going to be significantly problematic in patients getting a bispecific. So I would avoid bendamustine in those patients where you think CAR T may be in their future.
Yeah, that's interesting. Do you think about BTK inhibitors, looking at the data that maybe CAR T does not have as high of response rate when someone's refractory to BTK?
Yeah, I mean, I think it's a little bit hard to know what to make of all that data, because these are patients who had been fairly heavily pretreated, and then they get a BTK inhibitor. And, is it really the BTK inhibitor, or is it the fact that they've been heavily pretreated, we don't have a lot of other options? So I think that's an open question. Like, if we take patients who get a BTK inhibitor up front and then they relapse eventually, maybe CAR T will be in second line. Is that going to be a detrimental thing? I think we're really looking at bad biology of disease. And I think what we see across the board in the CAR T cell studies is people whose disease is not under good control, who've been heavily pretreated, who have cytopenias. These are the patients who don't do well with CAR T.
Yeah, it does kind of make you wonder, doesn't it, where, when does CAR T start moving up the line? I mean, and it's, I think right now we think of, or historically the most aggressive treatment was given up front, with chemoimmunotherapy with high-dose cytarabine and then consolidation with transplant. It's, not a stretch to think about something like, CAR earlier line, it seems like.
Yeah, absolutely.
What about for patients that have, Brexu cells become standard third line for patients with mantle cell since its approval a few years ago? Now that liso-cel has been approved, how do you decide between the two?
So I think the toxicity profile is going to determine who we choose for these therapies, at least now. I think we have shorter term follow-up for liso-cel, and the efficacy, at least now, doesn't look quite as good as what we see for Brexu-cel. So I would say in a younger patient who, we're going to be able to tolerate some neurotoxicity, because the neurotoxicity grade 3 and higher rates in Brexu-cel are about 30%. So it is, I think, the most toxic of the CAR T we use in lymphoma. You can get people through it, but you really want to have a pretty robust patient for that. So I think when we see patients who are older, who now we would really think that we shouldn't be taking them to CAR T, I think we'll think about liso-cel given the favorable toxicity profile. I think it's going to be interesting to see once we can get glofitamab, how that is going to compare, because that data is very impressive with complete remission rates and people who've failed CAR T that are very high. So I think that may be a game changer, and hopefully something that you all will be able to give locally.
Right, and I think that's one of the biggest issues with us is, when we're looking at these patients, we have some patients that we know that CAR T therapy is not going to be in our toolbox. And in some ways, we think of these bispecifics as being interchangeable in that line of therapy, although in some other lymphomas, the response rates aren't as high. And so we try to get people to Boston or to our referral centers to do CAR T, but that's really interesting to hear, also what you think about bispecific therapies and how that will integrate, because that is something we can do in the community.
Yeah, I think it's been really nice to see this sort of national group effort to try to put together guidelines, because we know we need to get these therapies into the community, because these are life-saving agents, and a lot of your patients are just, I met with a patient from Maine a couple weeks ago, and she just could not come to Boston to get a bispecific. There was no way it was going to happen. And, with good guidance and, pairing up together to have the support for everybody involved, I think we can give these agents safely. And I think we need to push that along.
Yeah, we spent so much time putting our sort of protocols together, and it's just a really exciting time to practice hematology and treat lymphoma and use these novel therapies and learn how to use them. So.
Yeah, it's really, I think back to when I started in mantle cell, and we did not have much. We used a lot of single agent cytarabine in patients who were relapsed and refractory. It was just when we were beginning to use rituximab, and now, it's unbelievable. Very exciting. John, thanks for joining me today. I really enjoyed your questions, and thank you to our learners.
Hi, thank you so much for having me today. It's always interesting and fun to discuss these new topics with you.
So please remember to take the post-test and fill out the CME evaluation. Please also join us for the other ASCO and EHA conference coverage videos, one where I'll discuss the treatment for CLL, SLL, and a second hot topics in other subtypes of non-Hodgkin lymphoma. My colleague, Dr. Ahmed, will review therapeutic options in diffuse large B-cell lymphoma and follicular lymphoma. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com.